All right, so this is the chapter 4 in your textbook, deals with fluid and electrolytes. So let's talk a little bit about the basics of fluid and electrolytes. Um, it is important to remember that we are approximately 60% water. So of a typical adult, our total body water is about 60%. So if you take a 70 kilo patient or a patient who weighs 70 kilograms, about 42 liters in their body is actually water total. Now, the older adult comprises a little bit less water, and the infant is made up of a little bit more water. So it is why, adults, the older adult, the elderly patient has a little bit less total body water, so they are more at risk for becoming dehydrated. They get dehydrated a lot faster, whereas the infant, which is made, the baby has more water, the makeup is of more water, they actually don't get dehydrated as quickly because they actually are made up of more total body water, okay? So out of this 60% total body water, the fluid is actually in different compartments. You have the intracellular compartment and you have the extracellular compartment. So it's important to know this because the majority of our water is actually stored inside the cell. So 40% of our total body water is actually intracellular. So again, for our 70 kilogram patient, we're looking at about 28 liters of fluid or water straight in the cells. 20% then of that total body water is in the extracellular compartment. So if you look down at this, if you look down here, you have the extracellular compartment being the interstitial space. The interstitial space is the space that's sort of between the cells, right in the tissues. So 15% of that extracellular compartment is filled with water. And the intravascular space is actually considered to be extracellular. So the intravascular space here. 15%, or I'm sorry, 5% of your total water is in the plasma of the intravascular space. So you also have a very small percentage of water in specialized cavities. You have water in the the cerebral spinal fluid. You have a little bit in the GI tract. You have the pleura, which is around the lungs, which cushions the lungs when you breathe. You have synovial fluid in your joints, which helps mobility of joints, and you have some fluid in the peritoneal space, again, sort of around the gut. So remember that for every liter of fluid, that's 2.2 pounds or 1 kilogram. So 1 kilogram is equal to 2.2 pounds, and so for every kilogram of body weight is 1 liter of water. Now, these body fluids and electrolytes play a very important role in maintaining homeostasis in our body, so they're very important. And our body fluids are really in constant motion because they're constantly transporting nutrients to the cells. They're transporting electrolytes in and out of the cell. They're transporting oxygen to the cell, and then they are also the water is carrying waste products away. So the body fluids need to be sort of in constant motion to be able to achieve this sort of homeostatic environment. Now, water and particles will move in and out of the extracellular spaces and the intracellular spaces or into the different compartments because of osmosis and diffusion. So if you remember, very simply, that diffusion is actually the movement of particles from a high to low concentration, and diffusion will stop when the particles are equal. So again, if you have a lot of particles on the left side, and you have a low amount of particles on the right side, diffusion particles will move from that higher concentration area to the lower concentration area to sort of keep things equal. Diffusion, you can have diffusion by, and if you remember from anatomy and physiology. You have particles move by passive transport. Passive transport is really a transport of particles that requires no energy. Particles will simply move when those concentrations are altered. So the particles will just move to the lower concentration through that semi-permeable membrane in order to even out the concentration. You can have also active transport, where particles need energy or ATP to actually get them to move. Sodium and potassium are two electrolytes that require active transport. They need energy in order to move. The particles are very big. Remember that the particles are electrically charged, so sodium and potassium are electrically charged. So in order to get sodium and potassium to physically be able to move across the cell membrane, they need energy or ATP to help do that. That's active transport, okay? So osmosis, on the other hand, so diffusion is the movement of particles, but osmosis is actually the movement of water from a low to a high concentration. And again, the movement of water will stop when concentrations are equal, or when hydrostatic pressure builds up and sort of opposes that movement of water, okay? So as the water moves across the semi-permeable membrane by osmosis, you have an area where you have more particles on one side and less particles on the other, and so the water will flow into the to the side where the high concentration of particles is. So water will flow there, and it does this passively. When the water actually moves, it creates something called osmotic pressure. Okay, so as the water is physically moving, it creates osmotic pressure. And it moves essentially. It's essentially drawn to that area of higher concentration by the amount of solutes that are located in the other area. Okay. So there's a couple of things. So osmosis is the movement of water. So as the water moves, it's going to create pressure on the solutes that are in that space. So as the water is diffusing, or as the water is moving across that semi-permeable membrane into the area of higher concentration, that water is actually going to create pressure. And it's going to put pressure on the solutes as it's going to move those solutes around. That is considered your osmolality. So when you say that the serum osmolality of the blood, that is the indicator of actual serum concentration. So how much water is actually inside the compartment that it's being measured. And we measure that mostly in the intravascular space. So in that extracellular compartment in the intravascular space is where we sort of measure osmolality. We also measure osmolality of our urine as well. We want to know if it's really concentrated or if it's really dilute. So the osmolality is the measurement of the osmotic pressure actually on the solutes. So whenever that water is moving, whatever pressure it puts on the solutes, that's the osmolality of the blood. So cells are affected by that osmolality of the fluid that sort of surrounds them, right? So cell membranes, remember, are permeable to water. The cell membranes are permeable to water. Water can flow across those cell membranes, and when the extracellular fluid roughly equals the intracellular fluid, that is an isotonic. You're considered to be isotonic, right? Because movement of water should stop when the pressures are equal on both sides of the cell membrane. Okay, so that's sort of an isotonic environment. So if the extracellular fluid, let's say, becomes if the extracellular fluid becomes hypotonic, that means that they have more water than solutes. Then water would flood the cell, and the cell will swell. So if the extracellular compartment becomes hypotonic, meaning there's more water than solutes, then water is going to flood into the cell, and that would cause the cells to swell. Okay? If the extracellular fluid becomes hypertonic, meaning that there's more solutes than water, then water would leave the cell and it would flow into the extracellular fluid, extracellular compartment, and that would actually cause the cell to shrink, and that could cause the cell to eventually die because the water, again, is flowing from an area of low concentration to high concentration. So this is a really important when you talk about IV fluids. Now, next year, you're going to learn about IV fluids. There are hypertonic solutions, there are isotonic solutions, and there are hypotonic solutions. So isotonic solutions are the one we give the most when we talk about giving something like normal saline. Normal saline is an isotonic crystalloid. It's an isotonic fluid that mirrors our intracellular fluid or our intravascular fluid. If we put isotonic solution inside the intravascular space, like we do with an IV, then that fluid is going to sort of stay right in that compartment because it is the same as our normal body water. If we put a hypertonic solution, let's say, if we put a hypertonic solution into the intravascular space, it's going to make the intravascular space hypertonic, which means it's going to have more solutes than water, and so that's going to cause that's going to cause water to move from the intracellular space into the intravascular space because the intravascular space is hypertonic. If we put a hypotonic solution, let's say, like half normal saline, if we put a hypotonic solution into the intravascular space, straight into your vein like we do, that is going to cause the intravascular space to become hypotonic, meaning there's more water than solutes, and that's going to cause solutes, that's going to cause water to flood the cell, right? There's more water inside the intravascular space. Now it's going to cause the water to shift into the cell because water is going to go to an area of higher concentration, all right? So it's really important to kind of understand how water and solutes move across these semi-permeable membranes because we, in fact, as nurses, are going to manipulate that environment when we give IV fluids, all right? So getting sort of the isotonic, hypertonic, and hypotonic terminology down pat is really going to be important because you're going to change in IV fluids based on what the patients need in their intravascular space. Okay. So we talked a little bit about serum osmolality. So again, serum osmolality is that indicator of serum concentration. How much water is there in comparison to the solutes that are in the intravascular space? Osmolality is going to increase with dehydration, right? Because if I have less water than solutes, then my serum osmolality is elevated. So osmolality increases with dehydration. If I have less water than solutes, then my serum osmolality is elevated. That means I'm hemoconcentrated. That means I have more solutes than I have water, so my serum osmolality would be high. Normal serum osmolality is 280 to 300 milliosmoles per kilogram. So again, if it's greater than 300, I am considered hemoconcentrated and I am dehydrated. If my serum osmolality is low, then I have less solutes and more water. So I'm overhydrated, or what they call hemodiluted. So that means my blood is dilute, okay? So again, serum osmolality, the measurement of the actual solutes and the osmotic pressure on the actual solutes, and it's measured in the intravascular space because that is where we draw blood from, okay? So Water is going to shift when there are changes in pressure that cause it to shift. Now remember, the fluids in our body are in constant motion, but they move because of changes in the actual pressure. So when there's an imbalance between the forces that normally keep fluid inside the vessel and those that normally push fluid out, you're going to wind up with something called edema. So the clinical term is edema, and so when you have pressures that normally are opposing each other to keep water in one spot, when one goes up or down, that can cause pressure, or that can cause, fluid to move to a different compartment, all right? So there's a couple of different kinds of pressures that you might see doing this, and that is where you see hydrostatic versus oncotic pressure. So hydrostatic pressure is really the force that's created by fluid within a compartment, all right? So inside the blood vessel, that is the force that's created by the movement of water itself, or by fluid itself. So for instance, in the blood vessel, that is blood pressure. Blood pressure is actually generated by contraction of the heart. From, if you remember, the left ventricle will pump cardiac output out. That blood flows from the left ventricle out into the aorta, and as that fluid, just that volume of blood, that plasma, gets ejected out of the left ventricle, it creates hydrostatic pressure as it flows through the blood vessels, okay? So gradually, as the blood flows, hydrostatic pressure decreases as blood moves through your body. So it's highest in your arterial end, right? Which makes sense because that is where your blood comes out of the left ventricle into the aorta, which is a very large artery. And so that is highest, hydrostatic pressure is highest at that end, and it's lowest all the way at the other end where you have venous capillaries, where you have the venous end of capillaries. So as blood flows through the, and you can see it over here, as blood flows through the capillaries or through these vessels, you wind up with opposing forces. Hydrostatic pressure is going to push water, technically push water against these vessel walls and potentially push it into the interstitial space. Now, it doesn't do that because you have an opposing force called osmotic pressure. So again, there's an opposing force, and osmotic pressure is the pressure that because you have solutes in this blood vessel here, and as this water comes across, the pushing of the water on the side of the wall is hydrostatic pressure. But because you have solutes, as the solutes create osmotic pressure, that osmotic pressure pulls the water in from the interstitial space. So essentially, it just stays where it's supposed to be. But these are the two opposing forces, hydrostatic pressure and osmotic pressure, that keep water in the intravascular space, which is where you want it to be most of the time, all right? Now, if hydrostatic pressure were to increase, then and the opposing osmotic pressure doesn't change, then hydrostatic pressure is going to force water across the cell membrane into the interstitial space. If there is a decrease in osmotic pressure, again, the decrease in opposing pressure will cause fluid to shift as well, okay? Oncotic pressure is the pressure that's exerted by the proteins in blood plasma on the cell wall. So again, as the water travels through this vessel, and you can kind of see it down here as well, you have proteins that are inside these vessel walls, inside these blood vessels. Well, as those proteins, which are large, they are in the blood plasma. As those proteins bounce around, right here, they bounce around the vessel wall here, they also create a pressure. They create oncotic pressure, okay? So the oncotic pressure is pressure exerted by the protein, which is inside the blood plasma on the cell walls. Higher pressure tends to pull water into the vessel. So proteins such as albumin. So albumin is a very large protein that is part of your blood plasma. It's too large to cross capillary membrane, so it is always, or should always be, in the intravascular space. But as the albumin bounces around in this intravascular compartment, it draws water into the intravascular space, and that is what oncotic pressure is, okay? Now, if you lose plasma protein, let's say you have a low albumin level, if you lose that, then you're going to have a decrease in oncotic pressure because now there's not enough albumin or there's not enough oncotic pressure to keep water or to pull water into the intravascular space. So when plasma proteins are lost, as in malnutrition, that reduces oncotic pressure, and what happens to the fluid is it tends to leak into the tissue. There's nothing to keep it in the intravascular space, and that leads to edema as well, okay? So anytime water shifts out into a different compartment other than so anytime it shifts from the intravascular space to the extracellular space or the interstitial space, it's going to cause edema, okay? So fluid, again, is going to shift when there is a change in pressures. Anytime any of these pressures change, then fluid is going to shift and essentially get trapped in a space that maybe it isn't supposed to be in. So again, when venous hydrostatic pressure increases, if you have an increase in venous hydrostatic pressure, then fluid cannot move into the intravascular space, and it gets fluid cannot move into the vascular space. So you see this in heart failure and fluid volume overload where you have excess fluid, right? Because if you have an increase in hydrostatic pressure, then you have it kind of stuck in this area, and so you'll see an increased blood pressure from that because it's stuck in the intravascular space. When plasma oncotic pressure decreases, fluid's going to stay in the interstitial space. If there's nothing pulling water into here, if there's nothing water pulling it into the intravascular space, then it's going to just get stuck out in this area here. So fluid is going to stay in the interstitial space. You see this when in liver failure patients. So when you have a loss of albumin, you have or in liver failure, when you don't have enough protein being made, you see something called ascites, and we're going to talk about ascites when we talk about the GI components and we talk about hepatic disease. But ascites is around your abdomen. So there's not, because you have liver failure, you have a loss of proteins being made, and so you have a loss of oncotic pressure, and so that causes fluid to be retained in the peritoneal space. There's only supposed to be a small amount of water in the peritoneal space or in that interstitial space around your abdomen, but because you don't have it being drawn into the intravascular space, it gets stuck or gets trapped in that compartment. So you also can have a fluid shift when interstitial oncotic pressure increases, right? When you have damage to the vasculature that allows protein to accumulate in the tissue. If protein is allowed to accumulate in the tissue, it is going to create oncotic pressure inside the tissue, and it's going to pull water into the tissue because it has an increase in oncotic pressure. Oncotic pressure tends to draw water in. You see this in patients with burns, right? You see this in patients with burns. Patients, when the intravascular space or the tissue is disrupted and protein leaks out into that tissue where it's not supposed to be, it bounces around a little bit and it creates an oncotic pressure that pulls water with it. All right, so again, lots of opposing pressures that cause fluids to shift, okay? So here you see a decrease in plasma oncotic pressure is going to lead to something called ascites. So these ascites, as you see this very large abdomen, this is actually fluid that's trapped in the peritoneal space around the peritoneal cavity that's sort of in the tissue around the tract. Over on the right-hand side, you see an increase in what is called venous hydrostatic pressure, right? So volume is sort of trapped in the intravascular space, and it's an increase in venous hydrostatic pressure. This is called jugular venous distension, or JVD. You see this in right-sided heart failure patients where you have a fluid overload or an excess in the intravascular space. You have a higher blood pressure and a lot more volume actually in that space, okay? Hydrostatic edema. You will see a lot of hydrostatic edema in your patients. We'll be checking for what they call pitting edema, especially in the lower extremities. This is what we call pitting edema. But pitting edema, when you hear that terminology in heart failure patients, is actually a form of hydrostatic edema. So this occurs when there's an increased hydrostatic pressure inside the vessel wall, pushing fluid out of the vessel. So there's an increased hydrostatic pressure inside the vessel wall that pushes fluid out of the vessel. Okay, so there's no opposing osmotic pressure to keep it where it needs to be. So it kind of pushes it into the tissues, and you see this in patients with hypertension, where they have arterial hypertension, or in patients with venous insufficiency. This type of edema tends to pool in your lower extremities due to gravity. When you're walking around or you have your legs dangling over the side of the bed, fluid kind of flows downward because of gravity, and because you have venous insufficiency, it doesn't return to the heart, and so therefore it stays there, and so now you have an increase in that hydrostatic pressure that kind of pushes fluid into the interstitial space. And so sometimes you may hear this terminology called pitting edema. Again, if you push on the patient's shin bone or their femur or tibia down there, or their fibula, you will actually get an indentation of the skin, and it stays there because the fluid is trapped in that soft tissue. When we talk about, treatments that are aimed at getting rid of hydrostatic edema, this is where we use compression stockings like TED hose. So if you work in a nursing facility or you work in a hospital and you've heard of TED hose or support hose, you put those TED hose on. Well, we use those TED hose in order to increase venous return and decrease that hydrostatic pressure, in which case fluid will then be drawn back into the intravascular space and hopefully be able to return to the heart. Okay. Diuretic therapy, again, is aimed at decreasing hydrostatic edema as well, pulling fluid from the interstitial space into the intravascular space, where then hopefully it can flow through the kidneys, and it can filter through the kidneys, and then you can get rid of the extra water. Oncotic edema is actually caused by a reduction in colloidal osmotic pressure of the plasma. So again, when there is a loss of plasma proteins, then you have a loss of oncotic pressure, and that is when fluid will leak out of the intravascular space into the interstitial space. You see this when you have low albumin levels or in hypoalbuminemia. Albumin is the most abundant colloid that creates oncotic pressure. So when you have a malnutrition state or you have a liver failure, you have a loss of albumin, and so therefore the fluid gets there's a loss of that intravascular oncotic pressure, and so you will see fluid sort of leak out. You see oncotic edema the most in loose connective tissue around the face, around the eyes, also seen in ascites around the abdomen. So that's considered loose connective tissue. It's very easy for fluid to flow in there when there's a loss of oncotic pressure, and it just kind of stays put in these areas where you have loose connective tissue. Okay, so just different kinds of edema that you're going to see in your patients, and just having an understanding as to what causes the edema and how to change the pressure inside the intravascular space in order for fluid to move in and out of the cells and in and out of the interstitial space like it's supposed to. Okay. So, well, how then do we regulate water? Well, there are a lot of ways that our body regulates water, and it is important for you to sort of learn about these, so you can read about these more in your book. But water is regulated by a lot of things in our body, actually. The first thing is that the hypothalamus actually plays a role in regulating water balance. The hypothalamus is located near the brainstem, and if you remember, the hypothalamus is what controls our body temperature. It controls hunger, but it also stimulates thirst. So when we have a loss of intravascular volume and we are dehydrated, the hypothalamus will kick in and stimulate our thirst center in the brain, and that will hopefully help trigger us to drink more water. And so It also stimulates the hypothalamus, also stimulates, has a role in blood pressure control as well, stimulates the posterior pituitary gland to release ADH, as we talked about ADH the other day. Antidiuretic hormone actually regulates the kidneys. So ADH actually increases the permeability of cells in the distal renal tubule to water, which allows water to be reabsorbed. So remember, if our intravascular volume is low, the posterior pituitary will secrete, will actually, the hypothalamus will stimulate the posterior pituitary to actually release ADH, which then triggers the distal renal tubules to reabsorb water in the hopes that the intravascular volume will increase, okay? So again, if plasma osmolality is increased, meaning there's more solutes than water, or there's a decrease in circulating blood volume, the kidneys will sense that, then ADH will be secreted and the kidneys will respond by retaining water. So antidiuretic hormone is just will help increase circulating blood volume and will do that by retaining water only. So the water will go straight into the intravascular space, okay, to change or lower the plasma or the serum osmolality if it was increased. Aldosterone is the other sort of key component in that. So again, we talked about aldosterone. Aldosterone increases sodium and water reabsorption. So again, in the distal renal tubule, aldosterone works right on that. Aldosterone is actually secreted from the adrenal glands, and it causes the kidney to increase sodium reabsorption. So if sodium gets reabsorbed, with sodium comes water. If you anytime you think about sodium being absorbed, think about water coming with it, because sodium and water kind of go hand in hand. So aldosterone, again, the renin-angiotensin-aldosterone system, we talked about that the other day. That comes straight from the kidneys themselves. Now, the kidneys, and that is used to increase blood pressure, excuse me. The kidneys sense also a decreased sodium delivery to the distal renal tubules or decreased renal perfusion. So the kidneys actually sense that, and they will, so both of those will trigger the renin-angiotensin-aldosterone system. And if you remember what we talked about the other day, the renin gets secreted into the plasma. It causes the conversion of angiotensinogen, which is made in the liver, to angiotensin 1. That angiotensin 1 mixes with ACE, which is the angiotensin converting enzyme, and that becomes angiotensin 2, and that causes blood vessels to constrict. That's why it increases your blood pressure, and it stimulates aldosterone, which causes the kidneys to reabsorb sodium and water, and that will increase blood volume. So it plays an important role in the regulation of water balance. In the heart, you actually have the heart plays a role in the regulation of water balance as well by secreting something called natriuretic peptides. So the natriuretic peptide that you will become most familiar with is something called BNP. BNP is brain natriuretic peptide is actually what it stands for, but BNP is actually secreted by your heart when the net effect of BNP is actually to decrease blood volume and lower systemic blood pressure and afterload. So afterload, we will talk more about when we get to cardiac, but afterload is essentially the force that your heart pushes against. So when you have a patient in heart failure, especially, but when you have an increase in blood volume, so let's say you have the renin-angiotensin-aldosterone system being activated and you have an increase, which increases blood volume, circulating blood volume, which is a good thing, but there comes a point when that has to be stopped, right, when it can be too much. So your heart will sense that increased volume and will start secreting something called BNP, which is a natriuretic peptide. Again, this is an antagonist of the RAAS syndrome. it's an antagonist, right? So it works against that renin system. So again, it works to counteract that, and so it's going to lower blood plasma volume. Okay, so it actually promotes natriuresis, which is the excretion of sodium and water via the kidney. So it's not that the RAAS system just gets turned off completely. I mean, it does get turned off a little bit, but if it was a little out of control, your heart will respond by releasing these natriuretic peptides, and that is an antagonist against that system. We also have the GI system playing a small role in water balance because we take in fluid and we hopefully release fluid. So again, we take in water, we drink it, it gets absorbed in our system and our cells take it in and our plasma volume takes it in. But all of that intravascular volume flows through the kidneys, and the kidneys will then excrete excess water if we need to. We also lose a small amount of water through our stool as well. We have fluid in our digestive tract, which is needed to break down food when we eat it, and we do actually lose a small amount of water through what is called insensible water loss. We do vaporize a little bit of water when we exhale from our lungs. We lose a small amount of water from when we sweat, so we lose it from our skin and our sweat glands. So again, a very, very large the body plays a huge role in maintaining water balance to regulate that homeostatic environment that your body is so needs to make in order to maintain homeostasis. So the first electrolyte that I want to review is, again, electrolytes are really, really important because not only do the cells need them, but they help maintain fluid volume, right? If we didn't have any electrolytes in our system, then our sodium-potassium pump wouldn't work, our muscle cells wouldn't work, but water wouldn't stay where it needs to stay because we wouldn't have any osmotic pressure, we wouldn't have any forces, we wouldn't have any reason for water to move from one compartment to another. So sodium, which is normally found in the extracellular fluid, sodium is normally 135 to 145 milliequivalents per liter. It's important to begin to know your lab values and get that sort of ingrained in your brain. But sodium has a direct influence on blood volume. So when you have an imbalance of sodium, you usually have an imbalance of water, and those imbalances typically parallel changes in osmolality. So again, when our serum osmolality goes up, we can probably say that when our serum osmolality goes up, that means that we are dehydrated. We have an increase in solutes and a loss of water, but imbalances typically parallel changes in osmolality. Okay, so with sodium and water kind of go hand in hand, and so a loss of sodium frequently is associated with fluid volume imbalances. Typically, we take in more sodium than we need. So when you have a loss of sodium in the intravascular space, you are said to be hyponatremic. So hyponatremia is a sign of low sodium. And there are a lot of things that cause hyponatremia. You can have an excessive sodium loss, which is an actual sodium loss. And you see that through GI losses and burns. When you have a true sodium loss, if you have excessive vomiting, if you have excessive diarrhea, if you are like when you're sick, anytime you have a loss of sodium, you actually have a loss of water as well. So hyponatremia can actually can be an actual loss through GI losses, burns as well, or you can have an inadequate sodium intake. People will do fasting diets, as well, and they won't take in enough sodium, or excessive water gain. So when you have an excess amount of water, let's say in times of heart failure, that is considered to be dilutional hyponatremia. So hyponatremia can be actual from actual sodium and water loss, or it can be dilutional from an excess of water, in which case the sodium, you look hyponatremic and you feel hyponatremic, but it's really dilutional. So if you get rid of the excess water by itself, then the sodium will correct itself. Patients who are hyponatremic tend to be very confused. They can be very irritable. You can actually, with a sodium less than 115, you can actually have cellular swelling, because what happens is you have lower plasma osmolality. If I have less sodium in my intravascular space, I don't have enough osmotic pressure to keep water there. So water moves into the interstitial space and into the cells, so you actually wind up with cellular swelling. Well, you get that in the brain, so cerebral cellular swelling occurs because of hyponatremia, and that causes a lot of confusion in patients. And so patients will complain of headaches, and a severe hyponatremia less than 115 can lead to seizures as well in the brain, because of the brain, and cerebral swelling. Okay. Patients will complain of being dizzy. They will sometimes have postural hypotension, meaning they have a change in blood pressure when they go from lying to standing, because again, they have a low sodium, and typically they have low water as well with that. Hypernatremia, on the other hand, is a high sodium level in the blood, so greater than 145 milliequivalents per liter. Hypernatremia can come from excessive sodium intake, which is actual hypernatremia, or you have inadequate water intake, right? If I just really stop drinking water altogether, I'm going to become hypernatremic, because I will have water loss inside the intravascular space, right? So excessive water loss as well can cause hypernatremia. If I'm just losing water by itself, you see this in diuretic therapy. You frequently will see hypernatremia in the elderly, right? The elderly tend to be they don't necessarily, that sort of thirst center isn't always working as well. Many times they just don't know that they're thirsty, so they don't drink water. Infants are the same way, right? Infants usually get thirsty, but they can't ask for water. So infants can sometimes become hypernatremic because they are thirsty, but they just can't get up and get a glass of water. Patients with hypernatremia tend to become agitated, restless. Again, you can become confused, and they can have a higher than normal blood pressure as well. So that's hypernatremia, okay? So all of the, you want to read about these electrolytes in your textbook in chapter 4, because they're all listed there as well. And there's the same slide that tells you about hyper and hyponatremia and what the signs to look for in your patients. Potassium. Potassium is another very important electrolyte. Potassium is important because it maintains the sodium-potassium pump in cell membranes, which is a process that is fueled by the breakdown of ATP. You need to be able to have this sodium-potassium pump in order for a lot of muscle cells to work, especially your cardiac muscle cells. They depend on a shift in the sodium and the potassium. So potassium, normally sodium flows into the cell, and normally potassium flows into the cell and sodium flows out, and that changes the resting membrane potential for this sodium-potassium pump. So the ratio of intracellular potassium to extracellular potassium is sort of the major factor in the resting membrane potential of nerve and muscle cells. So therefore, like the neuromuscular function and cardiac muscle cell function can be altered if there's a potassium imbalance, right? So normally the resting membrane potential is an exchange of 3 sodium for 2 potassium across the cell membrane. And when that potassium starts to shift, it begins to depolarize the cell, which leads to muscle contraction. And then after the muscle has contracted, the potassium and the sodium will shift again in the same ratio, and that will cause the resting membrane potential to return to its resting state. So potassium is very, very important to maintain that pump. We take in potassium. Our diet is sort of the main source of potassium intake. We take in approximately 50 to 100 milliequivalents a day from the fruits and the vegetables that we eat, and that is enough potassium to maintain that potassium level. Normally our potassium is 3.5 to 5 milliequivalents per liter. 90% of our daily potassium is actually excreted by the kidneys, and again, the sodium and potassium have a reciprocal relationship when it comes to reabsorption. So what causes sodium retention usually leads to potassium loss and vice versa. So they kind of have a reciprocal relationship. So when you have imbalances in potassium, you can see hyperkalemia or hypokalemia. So hyperkalemia, again, is when our potassium level is increased over 5.0 milliequivalents per liter. Hyperkalemia results from either massive potassium intake or, more commonly, the impaired renal excretion. So the kidney failure patient is the patient who's most at risk for hyperkalemia, true hyperkalemia, right? Because normally it's excreted, so if it gets reabsorbed, it's going to wind up staying in the intravascular space. And so you can have hyperkalemia, or anytime you have potassium that shifts from the intracellular space to the extracellular space. Anytime it shifts from inside the cell into the intravascular space, it will lead to hyperkalemia as well. But again, the most common cause is going to be renal failure. You also see patients who have hyperkalemia when you have patients with massive tissue injuries. So if you had a patient in a car accident or a massive crush injury, anytime you crush you have a crush injury and you think about think about your cells being just crushed, that is going to cause potassium, which is normally inside the cell, to leak into the intravascular space. So if it leaks out of the cell and it kind of goes into the intravascular space because of that crush injury, you're going to see hyperkalemia. The signs of hyperkalemia are, the initial sign is going to be leg cramps, but what will happen is you'll have leg cramping followed by weakness, and then you'll eventually have paralysis of your skeletal muscles. Usually the leg muscles are affected first. You can have tachycardia. So again, as the potassium levels rise, cardiac function is going to become altered. If cardiac cells cannot depolarize, then they will initially you're going to be first. You're going to see tachycardia, which is an increase in the heart rate, and then the cardiac muscle cells, if they cannot depolarize, then they cannot create that action potential they need to actually get that heart beating. Eventually that's going to lead to cardiac muscle standstill, right? Because if the potassium is outside the cell where it's not supposed to be, it's going to cause a loss of that action potential, and therefore you're going to wind up with an irregular pulse, and then eventually you're going to have cardiac standstill, okay? Because the cardiac muscles are not going to be able to function. And hypokalemia results from abnormal shifting of potassium from the extracellular space to the intracellular space. So if you have it shifting from your blood vessels into the intracellular space, so that can result from inadequate potassium intake or abnormal loss of potassium by the kidneys, right? So when our circulating blood volume is low, aldosterone secretion is triggered. We talked about that already. Well, that causes the kidneys to reabsorb sodium and water. And so again, if sodium and water, if you remember, have that reciprocal relationship, so if sodium is being reabsorbed with water, then potassium is being lost, okay? And so that can cause hypokalemia because now your kidneys are getting rid of potassium that maybe they shouldn't be. So in patients, hypokalemia again alters the resting membrane potential, but what it does is it causes a more negative charge within the cell, and that actually leads to reduced cell excitability. So in skeletal muscles, if this is going to cause weakness and paralysis. So you're going to, again, see this in the lower extremities first. Patients are going to complain of muscle weakness. They're also going to complain of paresthesia, which is numbness or tingling of those lower extremities. They may exhibit a decrease in reflexes, and they may also have bradycardia. And the reason they have bradycardia is because the cells cannot get excited, so that have that sort of altered reduced cellular excitability. So if they can't initiate the resting membrane, or if they can't initiate that depolarization as well, the cells can't get excited, and you will have a slow heart rate initially. Okay, you do see hypokalemia again in the elderly. Those patients who are taking potassium wasting diuretics frequently will have hypokalemia. Calcium is another very important electrolyte. Calcium is important because it helps with nerve impulse transmission. Calcium is needed for nerve impulse transmission, so nerve impulses to sort of travel along the nerve cells. Also important for myocardial contractions, right? Our heart does depend on calcium going in and out of the cell as well to have myocardial contraction, and also the formation of teeth and bones and muscle contractions. So very important. We need to have calcium. We obtain most of our calcium through ingested food. So we take in most of our calcium when we eat. Only about 30% though is actually absorbed. 99% of our body's calcium is actually found right in the skeletal system itself, and it's combined with phosphorus. So really, therefore, our bones serve as our ready source of calcium. Calcium is combined with phosphorus, and it is basically stored in the skeletal system. And calcium balance is controlled by the parathyroid hormone, also by calcitonin and vitamin D. So again, when you take in calcium, you actually also need vitamin D in your gut to help with absorption of that calcium. So that is why, because patients frequently do not have enough vitamin D, we can ingest a lot of calcium, but it may not increase our calcium levels. So it's kind of a misnomer when a lot of elderly people, or when a lot of people take calcium supplements. If you take a lot of calcium supplements, but you don't have enough vitamin D, that calcium supplements, it's not going to help you. It's not going to be absorbed enough to raise your calcium level, okay? So again, calcium is controlled by our parathyroid hormone. When our serum calcium is low, the parathyroid hormone actually releases, parathyroid hormone, or PTH, which causes calcium to be released from our bones. That is called bone resorption. So our bones will actually release calcium from our bones in response to that low serum calcium level, and it causes our GI tract to absorb more calcium, and it causes our kidneys to reabsorb calcium as well. So parathyroid hormone, a functioning parathyroid, is very important when it comes to calcium balance. So what causes, and again, when our serum calcium levels are high, the thyroid gland will produce calcitonin, which works against parathyroid hormone. So you kind of need that control to have calcium in its steady state. Calcium is present in 3 states. Just kind of quickly going back, you'll see there's an ionized calcium and a total calcium. So calcium is actually present in our serum in 3 forms. There's free or ionized calcium, which is sort of the biologically active form. So half of your total calcium is actually ionized calcium. Calcium is also bound to protein, mostly albumin, and also complexed with phosphorus. So we can have calcium sort of stuck to phosphorus as well. So usually the total and the ionized calcium are reported together, because you can have changes in one and not the other, okay? So, for example, you can have a change in your blood pH, so you can become more acidotic, and that decreases calcium binding with albumin. So therefore, your ionized calcium would increase, because now it's not binding with, it's free, right? It's not binding with albumin. So your ionized calcium would increase. or your free would increase. And alkalosis leads to decreased ionized calcium because it binds with protein then more. So when our albumin is low, our total calcium can drop while our ionized calcium remains normal, because you have calcium bound with albumin, and so if the albumin's low, then the bound calcium is low, but the ionized calcium is normal because it stays normal because that's your free calcium that's just sort of in your intravascular space, right? So your total calcium will drop, but your ionized calcium will stay the same. So you can have hypocalcemia and hypercalcemia. Hypercalcemia, culprits of hypercalcemia, when there's too much calcium in our plasma bloodstream, is hyperparathyroidism or malignancy. So when you have an overactive parathyroid gland, then you have more parathyroid hormone being produced, which causes an increase in calcium because it's telling our bones to let go of more calcium. That does cause our bones to become soft, and it causes bone destruction as the bones are releasing the calcium into the bloodstream, right? And so if our bones are becoming destroyed, patients with hypercalcemia actually are at risk for fractures because the bones are actually bone is being destroyed. So bone destruction equals the release of calcium into the bloodstream, okay? Prolonged immobility can also lead to hypercalcemia. Vitamin D overdose can also lead to hypercalcemia too, right? Because that's going to lead to excessive calcium being metabolized, because again, you need vitamin D in order to absorb calcium. So if I have an overdose of vitamin D or I have more vitamin D, then I'm going to wind up with that abundance of calcium in my bloodstream. Prolonged immobility, though, does lead to hypercalcemia because it leads to bone mineral loss. So as the bones actually kind of demineralize, that's going to release the stored calcium into the bloodstream. What will you see in patients with hypercalcemia? Well, you have reduced excitability of muscles and nerves. So patients with hypercalcemia leads to reduced excitability of muscles and nerves. So you're going to see weakness in these patients. You're going to see depressed reflexes. Their bones are going to hurt because their bones are resorbing calcium, which means they're just sort of letting calcium spill out of their bones where it's normally stored. Patients will be confused. You will see personality changes in them, and they have a hard time and they might have some weakness as well. You can also see cardiac dysrhythmias with hypercalcemia as well. In hypocalcemia, any condition that causes a decrease in parathyroid hormone can result in hypocalcemia, right? So after neck surgery, or if you have a portion of your parathyroid hormone or parathyroid gland removed, or if it's injured in some way, or hypoparathyroidism, or if you have impaired absorption of calcium and vitamin D. For instance, those patients who use laxatives, if you use a lot of laxatives, you actually wind up with a malabsorption syndrome. And so if I can't absorb calcium, if I can't absorb vitamin D and calcium, then I'm going to wind up with hypocalcemia. Low calcium levels allow sodium to move into excitable cells. So if I have a low calcium level, then my cells become a little bit more excitable. And so, because again, it changes the resting membrane potential because all of these electrolytes are charged, remember, electrically charged. So they're negative and positive, and as they move across that cell membrane, they're going to create a membrane potential. So low calcium level actually allows sodium to move into these already excitable cells, and what that does is it decreases the threshold of the action potential, and so nerve cells will become more excited, and then they wind up with a sustained muscle contraction. So again, it's a prolonged excitable cell. It's a sustained muscle contraction, and that is what is called tetany. So you will wind up with carpal spasms, you'll wind up with tetany and muscle cramping because, again, these are overexcited cells, and you wind up with hyperreflexia. So again, muscle cramps, because just think of overexcited cells, okay? These are two signs that you see, Chvostek sign and Trousseau sign. So Chvostek sign is a sign of hypocalcemia. If you tap on the facial nerve of the patient, it causes muscle spasm, facial muscle spasm. And again, if Trousseau sign is a condition of carpal pedal spasm, so you actually inflate a blood pressure cuff for about 3 minutes, and then you will wind up seeing with, you'll see these sort of carpal pedal spasms because the muscles are overexcited and they wind up with this sort of increased muscle contraction and they wind up in spasm. So that is considered Trousseau sign. So these are both signs of hypocalcemia in patients. Magnesium is another extremely important electrolyte. So we have potassium, sodium, calcium. Magnesium is also essential for all living things to survive. Magnesium is needed in the production of DNA and RNA, so our cells need magnesium, which is why you will see magnesium found mostly in intracellular fluid. It is a coenzyme in metabolism of carbohydrates and proteins, so it does help metabolize carbs and proteins. It is regulated by the GI tract and again by renal excretion, so the kidneys can conserve magnesium. If it senses a low level, it can excrete more. If it senses the level is too high. Magnesium is needed for cardiac muscle cell function as well. Magnesium acts directly on myoneural junctions of cells, so therefore if you have an alteration in your serum magnesium, you're going to have an effect on neuromuscular excitability. And magnesium is necessary for cardiac muscle cell contraction and normal cardiac functioning as well. So the alteration in magnesium is going to cause a problem with neuromuscular cells. So hypermagnesemia, when you have too much magnesium in your bloodstream, occurs in patients with renal failure who take in excessive magnesium. So you see this occasionally in patients who ingest too much Maalox, too much milk of magnesia. So those medications we take for heartburn, which are very, very common, are magnesium based. So patients with renal failure shouldn't take them because they won't be able to excrete the excess magnesium. So Maalox and milk of magnesia. And high serum magnesium actually depresses neuromuscular and central nervous system function. So initially patients will become very lethargic and drowsy in the beginning, and as those levels increase, it's going to lead to a loss of deep tendon reflexes, and ultimately what will happen is you will have respiratory and cardiac arrest from too much magnesium or hypermagnesemia. Hypomagnesemia, on the other hand, is seen in patients who have usually prolonged fasting or starvation. So you see low magnesium levels in alcoholics because frequently alcoholics tend to have that same picture of wasting syndrome or starvation syndrome. They have malabsorption syndrome because they're not taking in the appropriate nutrients. So you see this in alcoholics, and you see this in patients taking diuretics because you can have an increase in magnesium excretion. So this is hypomagnesemia. Low serum magnesium produces neuromuscular and central nervous system hyperirritability. So again, this is hyperirritability. So patients can be confused. If you're hyperirritable, then you have hyperactive deep tendon reflexes, you can have tremors, you can have seizures, and you can have cardiac dysrhythmias as well. So magnesium is very, very important. Normal magnesium is 1.5 to 2.5 milliequivalents per liter. Phosphorus, the last sort of electrolyte I want to talk about. Phosphorus is important because it's found in your intracellular fluid. Phosphorus, 85% of your phosphorus is actually bound to calcium in your bones and your teeth. So normally they are stored together. Phosphorus is needed, is an essential element for the production of ATP. So your mitochondria need phosphorus in order to make ATP. The body uses phosphorus to produce some of the structural components of DNA and RNA, which again are essential for life. So phosphorus is extremely important. Phosphorus aids in muscle contraction as well, including your cardiac muscles and other nerve cells. So for proper nerve conduction, you do need to have phosphorus in your body. Now, phosphorus has a reciprocal relationship with calcium. So as your phosphorus level increases, your serum calcium will decrease. Hyperphosphatemia, which is a high phosphate level caused primarily by renal failure. Kidneys can no longer excrete, when the kidneys can no longer excrete phosphorus, it will lead to high phosphate levels in your blood. May also be caused by excessive milk intake or phosphate-containing laxatives, so a lot of times we can just ingest more phosphorus. An increased phosphorus binds with calcium, and then the calcium gets deposited in soft tissues such as joints, corneas, arteries, and skin. So again, phosphorus is usually bound with calcium. So if you have too much phosphorus, then you're going to wind up binding extra calcium, and those complexes are going to get deposited in soft tissues and joints. You also can see neuromuscular excitability and tetany and muscle cramping because as you have an increase in phosphorus, it's pulling calcium with it, so then you wind up with hypocalcemia. So the hyperphosphatemia, remember, it has a reciprocal relationship, so it pulls calcium and binds calcium, which leads to hypocalcemia, and that is why you get the tetany, the neuromuscular excitability, and the muscle cramping, because those are the signs of hypocalcememia, okay? Patients can also become confused because it may lead to excess CNS depression as well. Now, hyperphosphatemia, neuromuscular excitability, confusion comes with hypophosphatemia, I apologize. So again, the biggest thing with hyperphosphatemia are all the signs of hypocalcemia. Hypophosphatemia, seen in malnourished patients or patients who have malabsorption syndrome. You again also see this in alcoholics and those that use large amounts of phosphate binding antacids, because again, phosphate, if it's an antacid that binds phosphorus in the gut, it's going to be excreted through your GI system, so you wind up with hypophosphatemia. The clinical signs of hypophosphatemia relate to a decrease in ATP production. All right, so it's going to result in impaired cellular energy and O2 delivery. You will also see hypophosphatemia because you have a decrease in ATP production. You also have a decrease in something called 2,3-DPG. You will see 2,3-DPG later on in the respiratory system, but it's an enzyme that red blood cells need to be able to transport oxygen to tissues. So if you don't have enough 2,3-DPG, you will be deficient in that, and that's going to result in impaired oxygen delivery to your tissues. So if you can think about your cardiac and respiratory cells that need oxygen, you may see patients being confused. You may see muscle weakness, but you can also see cardiac and respiratory muscle function decrease because they are not getting enough ATP production. There's not enough energy for the cells, and there's not enough oxygen being transported to the cells. So hypophosphatemia can be fatal. Okay, and here is just a picture of what those phosphate deposits in soft tissue would look like for hyperphosphatemia. Okay. The acid-base system is kind of the last part of what goes into regulation of fluid and electrolytes. Your body normally maintains a steady state between acids that are produced during metabolism and bases that neutralize and promote the excretion of those acids. So there has to be a balance between acids and bases in the body. So again, acids are normally produced when your body's cells metabolize all kinds of those different electrolytes and enzymes that are needed. And then you have bases that neutralize and promote the excretion of those acids, right? So once the body produces a lot of acid, there has to be bases in the bloodstream that help neutralize those acids as well. Because the body does not like to be acidic. If you remember, the normal pH of our blood is 7.35 to 7.45. Okay? So, the acidity or alkalinity of a solution depends on the amount of hydrogen ion that is present. So when you have an increase in hydrogen ion, it's more acidic, and when you have a decrease in hydrogen ion, it's more alkalinic, okay? And so the amount of hydrogen ion is actually expressed as our pH. That's where the H comes from in the pH, right? So it's the amount of hydrogen ion, okay? So, and it is what is considered to be a negative logarithm. So the lower the pH, the more hydrogen ion is present. So the lower the pH, the more acidotic I am. The higher the pH, the more alkalinic I am. So again, the pH is the amount of hydrogen ion, and it is a negative logarithm. The lower the pH, the more hydrogen ion is present, which means the more acidic I am, or acidotic if you want to call it that way. And the higher my pH, the less hydrogen ion that's present, and the more alkalinic I am, or the more base I have, okay? So again, pH normally 7.35 to 7.45. pH less than 7.35 is considered acidosis, and a pH greater than 7.45 is considered alkalosis, okay? And the body's metabolic processes constantly make acids, and these acids have to be neutralized and excreted by the kidney in order to maintain acid-base balance, okay? So in order to maintain the pH between 7.35 and 7.45, there are three systems that do that. The buffer system, the respiratory system, and the renal system all play a role in maintaining this pH level, okay? The buffer system is important because it is the fastest acting system, and it is the primary regulator of acid-base balance. So again, the buffer system reacts immediately. It is the first one that you will see coming into play when you are trying to regulate hydrogen ion, okay? This is the carbonic acid bicarbonate system. You probably remember this. This happens in the extracellular space. So this is what's actually going to happen right in the extracellular space, so outside the cell. The carbonic acid bicarbonate will actually neutralize hydrochloric acid in our blood, so it will break down the hydrochloric acid into water and CO2. The hydrogen phosphate system will actually work intracellularly. So right inside the cells themselves, the hydrogen phosphate will break down into sodium and water, and sodium biphosphate then gets excreted by the kidneys, okay? Some of the amino acids of proteins contain free radicals, which can dissociate into CO2 and hydrogen. So, and other amino acids contain radicals that can dissociate into ammonia and hydroxide. And so the hydroxide can then mix with free hydrogen ion and form water. Okay, so a lot of times right inside and outside the cell, things will amino acids and free radicals will dissociate into different particles that can then dissociate into other things that can mix with the hydrogen ion itself and create water. The hemoglobin actually assists in regulating pH because it can shift chloride in and out of red blood cells in exchange for bicarbonate. So again, if you need to buffer the blood and you need to be able to exchange for bicarbonate, the hemoglobin can help us do that. Buffers cannot maintain pH without adequate functioning of the renal and respiratory systems, though, because once the buffer system works, the body has to get rid of the waste product, right? So once it makes water, it's got to get rid of the excess water. Once it makes, hydrogen, once it makes CO2, your respiratory system has to be able to get rid of the CO2 and the water. So again, the buffer system works great, but it has to have a respiratory system and a renal system that function appropriately in order to get rid of the excess waste products that just were buffered. So as the acids are buffered, the body then has to be able to get rid of those waste products in order for it to function adequately. Okay. So it does that through the respiratory and renal system. So the respiratory system responds in minutes, and it takes max effectiveness in hours. So again, the carbonic acid bicarbonate system will work first, and once the CO2 and extra water are sort of in the bloodstream, the lungs will then excrete CO2 and water. Okay, so the lungs can help maintain that normal pH by excreting the CO2 and water, which are byproducts of cellular metabolism, right? So in the pulmonary capillaries, for instance, CO2 is formed and excreted by the lungs. So essentially, the exchange of CO2 and O2 and oxygen occur at end expiration physiologically. So when we breathe in oxygen, our body essentially breathes in oxygen in exchange for CO2. We breathe out CO2, okay? So the rate of breathing is actually controlled by the respiratory center in our brainstem. So if the brainstem, those chemoreceptors that are right there at the brainstem, if there's a sense of an increase in CO2, like let's say there's an increase in CO2, then your respiratory rate and your depth of breathing is going to go up or increase. And it's going to do that in order to blow off the CO2, okay? And the opposite is going to occur if their CO2 is decreased. So if I have respiratory acidosis, so when I have respiratory acidosis, I have a low pH because remember I'm acidotic, and I have a high CO2 level because that is considered acidosis, okay? So when there's a high CO2, and hypoventilation causes that. When I have that high CO2 level, my brain senses that and stimulates my respiratory rate, my respiratory center. So my respiratory rate will go up in order to blow off the high CO2, right? So again, that's why the buffer system works great, but my respiratory system has to work because as the CO2 level is rising, my body has to be able to blow off that CO2, okay? Respiratory alkalosis, on the other hand, is the other way. I can have a high pH, which means I'm alkalotic, and I have a low CO2, which means that's alkalosis, right? So hyperventilation causes me to blow off CO2. So the reverse can happen, right? So again, it's a system that works so that I can, if I'm already acidotic, I'll blow off CO2 to become more alkalotic and hopefully get back into that normal range. But if I continue to hyperventilate, eventually my pH will go up, which is what's supposed to happen, but my CO2 will go down and I'll be more alkalotic, okay? The renal system also helps. The renal system takes a couple of longer to respond. It takes 2 to 3 days to actually have this response. So again, the buffer system is working like it's supposed to, but the kidneys will kick in later. The respiratory system is going to kick in first to try and get rid of CO2, but the renal system will then kick in later to help with whatever the respiratory system couldn't help with. So the kidneys will reabsorb the bicarbonate that is filtered in the buffer system. And then it can actually generate additional bicarbonate and eliminate excess hydrogen ion as needed to compensate for acidosis. So if I am too acidotic, which means I have too much hydrogen ion and my pH is low, because remember it's a negative, so the more H I have, the more acidotic I am. My kidneys will kick in to reabsorb bicarbonate and generate additional bicarbonate and then hopefully get rid of the excess hydrogen ion or get rid of the excess acid, which will help bring my pH back to a normal range. So metabolic acidosis, if I have a low pH, my CO2 is usually not an issue, but the issue then, because we're talking about the renal system, is the bicarbonate system. Metabolic acidosis is frequently caused by renal failure or lactic acidosis, where I have an acidotic environment or a low pH, And I have a low bicarbonate level, which means I have too much hydrogen ion. That's metabolic acidosis. Metabolic alkalosis is sometimes caused by excessive GI losses. Again, my pH is high, I'm alkalotic, and I have a high bicarbonate level. I'm too alkalotic, which means I have a low acid level, okay? So just understanding the whether it's a respiratory and metabolic problem will help be able to figure out whether or not the CO2 is an issue or it's the bicarbonate that's an issue, okay? So the body depends on the kidneys to normally excrete acid that's produced by the cellular metabolism. That is why our urine is naturally acidic, because our kidneys are constantly getting rid of that excess hydrogen ion. So then if I'm getting rid of that hydrogen ion, it's going out of the body. And that is why the urine is acidic by nature. Okay. So again, really, really important to have an understanding of just these sort of foundational acid-base balance. We are going to talk more about this when we talk about the respiratory system, because that is where you really have to have a much better understanding of, that's where you kind of, this basic acid-base balance or regulation of the pH becomes very important in respiratory, in the respiratory system as well. Okay.